Okay, so today I'm going to present a small portion of work from my PhD studies on the impact of a nurse-led model of chronic disease management in general practice. So today I'm just going to present the patient's perspective of this. So obviously there's a lot more information from the PhD which we don't have time to even think about today. But this is a very important part, which is why I chose to present this session this morning, or was accepted to present this session this morning. The main project, as was just mentioned, was the feasibility, acceptability and cost-effectiveness of nurse-led models of chronic disease management in general practice. And this was an Australian Research Council funded project which had a large team associated with it, which I'll show you on the next slide. It was conducted jointly by the University of Queensland, Griffith University and Bond University. And my project was assessing the impact of the nurse-led care on the patient's health and quality of life. But today, as I've mentioned, I'm just looking at the patient's perception of this nurse-led care. So here you can... okay, I'm not presenting. Sorry, I've got to move the slides on here as well as mine. Okay, so there you can see the titles. And here is the project team. On that team, Dr. Diane Ely was one of my supervisors, as was Elizabeth Patterson, who's presenting tomorrow. I've noticed, I'll just move that out of the way. And also Desley Hegney was one of my supervisors as well. And there you can see also the practice partners. Do you need to do something? No? Okay. So we had 3 practices that were involved with the research, one in regional Queensland, one in urban Queensland, and one in rural Victoria. So today I'm just going to give a brief overview of my research aims, some of the literature which led to this research, a brief outline of the methods of inquiry that we use for the research, or that I use, discuss some of the findings, and then talk about some of the recommendations from the research. So let's have a look at some of the literature and the supporting the need for this research, and some of it I think you'll already know. Some of it was mentioned this morning at the breakfast session. I went to the diabetes one, which is very relevant to this presentation. So looking at the burden of chronic disease, within Australia the burden of chronic disease is reaching epidemic proportions, as we know, with the following statistics verifying this. Cardiovascular disease continues to be the single largest cause of mortality in Australia, today accounting for over 30% of all deaths. 17% of deaths in Australia are attributed to hypertension, which is associated with ischemic heart disease, stroke and hypertensive heart disease. Diabetes is the fastest growing chronic disease, with an estimated 280 Australians developing diabetes every day. And as we know from that presentation this morning and other literature which supports these, half of these people don't actually know that they have diabetes. A recent Australian Health Survey of biomedical results for chronic diseases found that only 55.7% of people aged 18 years and over with diabetes are effectively managing their condition with a glycated hemoglobin of 7% or less. Further to this, only 12.8% of people with known diabetes meet the target for a normal body mass index, which, as we know, is the score between 18 and 25. And it is also found that 1 in 3 Australian adults, or 5.6 million people, had high total cholesterol levels. In regards to health literacy, which was also mentioned this morning, it has been reported that among Australians aged 15 to 74 years of age, less than half, which is 41%, have an adequate or better level of health literacy. That's a scary statistic. People who have poor health or fair health are more likely to have both long-term conditions and inadequate health literacy, which may affect their ability to manage their condition. Advancing health literacy through primary healthcare systems has been recognised as a way forward in encouraging health promotion and preventative activities, as much as the information required by patients is time and condition specific. So the World Health Organization defines health literacy as the cognitive and social skills which determine the motivation and ability of individuals to gain access to, understand and use information in ways which promote and maintain good health. Health literacy is more than being able to read pamphlets. It includes enhancing access to health information and improving the ability of people to use this information effectively. It means that healthcare providers need to move beyond just providing information, but empowering individuals to become active participants in their own healthcare. For nearly 2 decades, the World Health Organization has been suggesting that healthcare workers should be targeting high-risk patients and monitoring lifestyle risk factors, which could prevent the advent of chronic disease and also prevent the complications associated with them. The considerable increase in chronic disease over the last few decades has become a global problem, and I think it's been inadequately addressed. So when it comes to health outcomes, only 1 in 7 patients are reaching recommended targets for glycemic, blood pressure and lipid targets combined. And it is estimated that 50% of patients with chronic diseases do not receive best practice management, highlighting the inadequacies of current healthcare management, which focuses on acute problems and urgent needs of patients. Internationally, research has been conducted which has highlighted the significant impact that nursing in general practice can play in relation to the management of chronic disease. The research has shown that nurse-led care in general practice can significantly contribute to improved outcomes in patients with type 2 diabetes and ischemic heart disease. Some of the outcomes of the research are decreases in mean systolic and diastolic blood pressure, decreases in cholesterol levels, improvements in HbA1c, decreases in BMI, decreases in anxiety and depression, and a decrease in the number of patients smoking or smoking cessation increase. And added to that, an increase in daily activity, changes to diet, and improvements in renal function. So the intention of this study, which was conducted, was to inform the current debate of the role of the nurse in Australian general practice. So the study was divided up into 2 phases, and I don't really need to go into this too much. I just want to give you a bit of an overview of how it was conducted. The first phase was a quantitative phase. I used a mixed methods sequential explanatory design, which I know most of you go, what on earth is that? But it basically just consisted of 2 phases, a quantitative phase followed by a qualitative phase. So we collected data in the quantitative phase, such as demographic data, clinical data, health-related quality of life data from the patient sample. And in the second phase, I did interviews with the patients from the first phase, which we purposely selected to try and explain some of the results that we found and build on those results. So the largest study, within the 3 practices, we searched the databases, the practice databases, and we found 830 eligible patients. You can see the acceptance rate there varied between each of the 3 practices, and in the end, we ended up with, in the practice nurse-led arm, which is the intervention, 127 patients, and in the control arm, 136 patients that completed the study. So just to give you some idea of what this nurse-led collaborative care model was, the registered nurses in the practices the participants were leading the intervention, and they led the management of the patient's care following clinical protocols that were designed for the purposes of the research. All of the practice nurses in the study attended an education program specifically designed for the research project. They used protocols in conjunction with individually tailored chronic disease management plans, and the plans were established at an initial consultation with the patient, and they were conducted by both the GP and the practice nurse. The practice nurses worked in an advanced role. However, it was emphasised to them that at no time were they to work outside of their scope of practice as identified by the competency standards for nurses in general practice. So phase 2 doesn't seem to want to. Oh. Phase 2 was the qualitative phase, and in this phase, the patients were interviewed. They were purposely selected, as I mentioned, using information from the quantitative analysis, and this was done to gain a more in-depth understanding of the quantitative data. So I conducted individual interviews with the patients, and this then gave me more information, which we're going to look at in a minute. So 10 patients in total were interviewed. Doesn't sound like much, but when you're doing these interviews for around an hour with each patient, then you have to analyse the data. You get quite a lot of data from them. So 10 participants, 5 each, male and female, were interviewed, and their ages range from 56 to 85 years, with a mean age of 75. Each participant had one or a combination of the chronic diseases of interest. That was the hypertension, ischemic heart disease, and the type 2 diabetes, as you can see there in the table. So results, which is the important part. 3 themes emerged from the qualitative data analysis, and they had sub-themes underneath those themes, which I'm going to show you now. And I'm using verbatim quotes from the patients to highlight what the patients actually thought about the nurse-led care, and I'm going to comment on those comments. So the first theme which emerged was time. And what they said, that there was no time with the GP. So the participants felt that the GPs were limited in the time that they could spend with each patient, and there was always the perception of feeling of being rushed when they were seeing the GP. I'm sure you can relate to that. The participants also sensed that the GPs were running late, and hence they did not want to bring up any issues in the consultation, as they felt the GP would not really want to know about it or wouldn't have time. Similar findings have been found in other research when examining a wider role for practice nurses in the treatment of minor illnesses in primary care, and the participants in that study thought that there were many negative aspects of consulting a GP, in that they were always busy, lacked time, and could appear uninterested at times. The second theme under time was more time with the PN. The patients believed that the PN-led care facilitated better access to health care, and that there was more time dedicated to the consultation. Similar findings have also been found in literature, also due to nurses having longer consultations with the patients, which our nurses in our research also had longer consultation times. So obviously they're going to come up with this more time with the PM. This finding has also been associated with increased patient satisfaction. The increased time the patients spent with the PN, though, meant that their health problems were being heard and that their encounter was being validated. The dialogue had become a two-way process where problems could be discussed and assistance was sought. And there you can just see another comment from one of the patients. What they were recognising here with this comment, which I thought was important to see, was that they could recognise that maybe sometimes they just needed to see the practice nurse, and then the GP could deal with other patients that needed more acute attention. So the second theme that emerged from the data was ambience, and this had 3 sub-themes, and the first one was more relaxed. The patients felt more relaxed in the consultation and believed that the atmosphere of the consultation was better. It was more personable and enjoyable, and the nurses subsequently were more able to motivate the patients. These findings are not uncommon, and even the earliest research conducted in Australian practice nursing back in 2000 reports of the approachability of PNs as opposed to GPs was noted. The second theme was better atmosphere, and the participants here felt that the consultations with the PNs were more pleasant and that nurses inquired about the participants' health. They actually asked questions. Again, similar findings have been found in other research studies where patients thought that nurses were easier to see and that they were more approachable. The participants also thought that the nurses listened and were more interested and involved in the patient care. Likewise, in our study, the participants felt that the PNs were more interested in them and would discuss issues of concern that they may have. This led to the perception that the consultations had the better atmosphere. Similarly, other studies have found that patient perceptions of nurse-delivered cardiovascular prevention found that the patients felt listened to immediately and that they understood each other. The third theme was encouraging. So this is the sub-theme under the ambience. The patients found visiting the nurses encouraging, and they responded positively to the increased focus on the management of their lifestyle risk factors. The motivational aspect of the PN-led care seemed to have the most positive aspects on the participants' dietary and exercise habits, which is important when we're looking at these chronic diseases. Similar results were found in a study in the Netherlands where patients in PN-led care started to exercise more compared to the control group, which is usual care with GPs. In this study, the nurses set short-term goals and with the patient for management of their lifestyle risk factors. Similarly, in our study, the PNs made appointments with the patients based on their needs and guidance from the clinical protocols that we used in the study. The participants also acknowledged that the regular follow-up with the PNs was beneficial and assisted them to stay motivated. I think they were scared because they were going to be put on the scales every time they came in or something like that. So the third theme, main theme from the study was dimensions of the nurse role. And again, this has 3 sub-themes. Therapeutic relationship, and I think we heard some of this morning with the plenary session. The first theme under this is a very important theme, and the therapeutic relationship which developed between the participants and the PNs was a major feature of the PN-led model. The participants perceived that they were being treated as an individual and that the PNs were working alongside them. And I think Brian brought up, the eye to eye. He mentioned that this morning. The PNs were providing health information in a timely manner, which was easily understood and appropriate, which increased the patient's health literacy and increased their ability to participate in decision-making and enabled them to better self-manage their chronic diseases. The respectful, positive dialogue which occurs between the patient and a nurse can promote behaviour modification, such as maintaining healthy diet, adequate physical activity and smoking cessation. As we know, patients often struggle, or we all struggle, to achieve recommended targets for these modifiable risk factors, which optimise healthy outcomes. Therefore, a therapeutic relationship which is based on trust and enables participation in decision-making increases the likelihood of better self-management. These lifestyle modifications then in turn may impact on improving glycemic control, lipid abnormalities and hypertension, and some of the more severe macro and microvascular complications that we see. The second theme under the dimensions of the nurse role was the educational role, and the nurses spent considerable time explaining to the participants information about their condition and care, and some of the patients said that they were going through it all. Education regarding the lifestyle risk factors was a major part of the consultations, and the participants recognised the importance of this. They also felt that it was a critical element in the management of their chronic diseases, and it enabled them some ownership of their own health care. The PNs were able to maximise the participants' understanding of their chronic diseases by providing health information which was appropriate and relevant. I've got a lot more information here, but I'll just skip over some because I know we started a little bit late. As part of the consultation, the nurses were using the smoking, nutrition and alcohol physical activity guidelines, the SNAP guidelines, and these have been found problematic for GPs because they often find it difficult to find the time to go through these with the patients because of their already heavy workload. So the third theme under the dimensions of the nurse role was clinical knowledge, and the participants' appraisal of the practice nurse's clinical skills was that, and I don't mean to be sexist here, she does everything. Not only did the participants perceive that the nurse was virtually doing what the doctor did, but they also commented that the care was much quicker. That is, the practice nurse did everything that was required, such as blood pressure, weight, BSL checks, and they just needed to get a prescription from the doctor. Obviously, this is an oversimplified version of a GP scope of practice, but one which is the reality for many patients with chronic diseases. Although it was acknowledged by some participants that nurses could be limited in their ability to offer advice and that they still needed to discuss certain clinical conditions with their GP. So the participants had developed their own evaluation of the nurse's scope of practice and determined when they needed to consult with the GP, which I think is important. So here you can see I've just put it all together, the time, the ambience, the dimensions of the nurse role, and how that can actually have an impact on patients' health. So limitations of this study was it was only carried out in 3 general practices in 2 states of Australia, and often patients agreeing to participate in studies may have a greater interest in their own healthcare. There are obviously some other limitations to the quantitative data collection, but I'm not reporting on that now. So some of the recommendations that I think we need to consider is that there is an urgent need for nurse researchers to work collaboratively with practice nurses to improve the quality and effectiveness of primary health care. The conduct of high-quality, clinically oriented nursing research which supports and promotes best practice will assist with providing nurses in general practice an evidence base for providing care. As new opportunities and roles emerge, a commitment to promoting and supporting research will enable practice nurses to shape their future and guarantee that they make a contribution to the global health challenge of chronic disease. Not that they already aren't, but I think we can form a much better evidence base. Developing an evidence base for nursing practice in general practice, I think, is a high priority in Australia. So much of the published literature within Australia on practice nursing is very descriptive, with little research focusing on new models of care and the associated patient health outcomes. So extending this research to other diseases and other areas in which nurses could take a lead role in the management of illnesses, such as mental health, women's health and child health, would assist with the development of the practice nurse role in Australia. Also, further research evaluating the impact of practice nurse-led care or a collaborative model of care in the primary healthcare context on health literacy is required. This research would need to evaluate the impact of PN-led care on health literacy, assessing outcomes such as changes in knowledge, behaviours, disease complications and the use of health services. I think this research is needed urgently in order to address the serious deficiencies in health literacy in the Australian population. So in conclusion, the variety of roles that the practice nurse inhabits and the extra time that they spend with the patient enhances the health experience of the patient and in turn enriches their encounter. The empowerment of patients is essential if they are better self-manage their chronic diseases. The findings from this study are encouraging and highlight that practice nurse-led care can have a beneficial effect on patients by increasing their health literacy and enabling them to make decisions about their own health care. And there's some references. And I just put the clinical protocols at the end if you wanted to see sort of what the nurses were working from. These were developed as part of the research group.